Welcome everybody to the fourth Cyber Systemic Interact. It's about intelligent technology implications on healthcare. And today the introduction is going to be performed by Claudia Perillo, by Anna Roberta Gagliardi, and by Žan Domanjko. So girls, guys, the floor is yours.
Okay, thank you. As you have said, the team is composed by me, Žan, and Roberta. And today we discussed the theme of the intelligent technology implication on healthcare. The aim is to introduce the discussion on how intelligent technologies are affecting people, healthcare workers, organization, and all the industry. So in which way the role of new intelligent technologies are reshaping the healthcare ecosystem. At first, we should say that the healthcare context is characterized by the elderly of the population and the increase of chronic illnesses. And more often, these chronic illnesses happens in comorbidity. So the complexity to manage is very high, and this context is somehow creating the need for a much more complex healthcare provision for patients and also a higher number of services required by the patients. On the other hand, we have to consider that healthcare is a system that its character is dynamic, is complex, and the actors that are inside the system are interdependent with each other. Furthermore, given these two basic premises to understand when we are the basic feature of the context, we have to consider also that COVID-19 pandemic has somehow accelerated a transition in healthcare, a transition that perhaps was already ongoing, but for sure that has been accelerated by the pandemic. Indeed, before the pandemic, most of the healthcare provision models were patient-centered and hospital-based. With COVID-19 pandemics, we understood that to face the complexity of healthcare, to face the crisis situation, it was necessary a perspective which was community-centered, and to analyze this context, to analyze this transition of the healthcare provision, we should have some criteria to understand how it's possible to pursue a transition in the healthcare framework, in the healthcare provision patterns. The criteria we select are effectiveness, efficiency, and sustainability. And we put effectiveness at first because the most important thing is to ensure the effectiveness of the care. We are talking about human healthcare, thus we have to take at first into account the effectiveness of the care. Then the efficiency due to the strict boundaries, the economic boundaries we have, and then also the sustainability of the care. And to do so, we use the viable system approach that suggests us to take into account the context condition, to consider the context condition. In this framework, we see that ECT and big data are creating, and also did during the COVID-19 pandemic period, ECT and big data are making disruptive changes in the relationship between the different actors involved and between processes, peoples, and infrastructures. And somehow these disruptive changes are also reshaping healthcare, and more precisely, healthcare provision patterns. Thus, at first, we start asking if there are enabling conditions for this future healthcare, which is much more based on community provision, and which is the role of artificial intelligence and digital technologies in developing this future healthcare. So at first, a first general level problem is how artificial intelligence could change healthcare. Thus, to go through the problem and to further analyze this general question on the pharmaceutical industry, I leave the floor to Žan.
Hi. As you heard from Claudia, the healthcare chain consists of three unrelated stakeholders: patients, medical staff, and pharmaceutical companies. AI allows us to connect the main players and bring the added value to all elements of the chain. At the same time, with the emergence of connecting link, an information transfer agent must be placed in the changing environment. As an employee of pharmaceutical company, I will focus on the view of pharma industry. In pharmaceutical development and manufacturing, AI can provide opportunities for process improvement, so carry out the quality control, shorten production time, reduce material waste, and etc. Such use does not only mean more reduced implementation, but also enables the search for process deficiencies. It also enables the identification of candidates for clinical testing, which would shorten the time from development to registration of medicines. Of course, with this system changes, we must ask us how to balance the system so that there is no dominance. You are thinking about approach of taking action, somehow regulating the system in order to properly design a solution or system with the help of, for example, a system dynamic method or any others. Another approach would be the design system by observing the behavior of players through agent-based system analysis method. At the same time, the issue is the morality in the transmission of information between independent stakeholders opens up for us here.
Thank you, Žan. And let's hear from Anna Roberta.
Good afternoon, everyone. First of all, thank you for having me here. In recent years, the health sector has seen a shift in the delivery and utilization of health services. New regulation, easy access to information for patients, and technological innovation have gradually shifted the focus to the citizens and patient experience. So we started to talk about triple aim, which is a strategy. The Institute for Healthcare Improvement has identified three goals to accomplish this. The first is improving public health. The second, improve the patient experience, including care quality and patient satisfaction. And the third, lower the cost of healthcare services. There has recently been a need to include an additional key component: healthcare workers. It is extremely difficult to believe you can achieve the three objectives listed above without a sufficient focus on staff, on healthcare staff. In contrast, it is well known that an improvement in the quality of clinical and healthcare personnel's work can significantly impact in the quality of care and assistance provided to the patient. We move from the triple A model to the quadruple A model, where the fourth objective is improve the experience of staff working in healthcare. This model includes healthcare workers' well-being, which can achieve by improving work conditions with a focus on burnout-related situations. Healthcare organizations should be more proactive in preventing health problems before they occur. Digital technology is critical for this paradigm shift because it can help healthcare workers better understand how to keep patients healthy by incorporating data-driven insights on well-being and decision support tools, recommended treatment plans. Therefore, in conclusion, to gain a strong position in the future standard of care, the added value of health technology innovation will need to be demonstrated on all four pillars of the quadruple aim. Again, thank you so much. And Claudia has the floor once more. I conclude my brief, but I hope stimulating presentation. Thank you.
All right, yes. Thank you, Roberta. As Roberta and Žan has said, there is a huge potential for new technologies, much more for digital technologies in healthcare. And these healthcare reshaping is being affected by these new technologies implementation. And somehow organizations are under pressure to adopt new digital technologies and to implement new models in which digital technologies are integrated, pursuing this paradigmatic, as said by Roberta, this paradigmatic shift, increasing the availability of care, for example, reducing the barriers for patients, increasing the number of data useful to better inform decision-making process, and so on. And in this, from this viewpoint, we are also renegotiating the professional boundaries. So, as Roberta said, the relevance of the staff in leveraging a higher density of produced, collected, and analyzed data, we could achieve healthcare services performances which are better because we have data on which we could bettering the service offering. So to conclude, we can say that artificial intelligence is changing the medical practice, and the recent progress in data acquisition, machine learning, and computing infrastructure, the application of these new technologies are expanding the way in which patients could be treated. So artificial intelligence is really disrupting healthcare. But we have still some questions, being it quite recent in the application, we still have some questions that we want to address to you in order to understand which could be the direction of further researches. So, which is the role of these technologies today? Is that a simple instrument for healthcare practice or also artificial intelligence and other digital technologies are a key driver for value creation? And for example, another question, we use the viable system approach. Perhaps there are also some other methods to analyze, to address the problem. So if some of you has got any suggestion, we are glad to listen to it. And if you have got any questions, we are here to answer it.
Thank you, Claudia. Thank you, Anna Roberta, and thank you, Žan. I think you've opened a huge issue there, which is not going to be easily solvable with a magic stick. But I do hope that we, in this particular CSI, have an option to basically try to open it from different perspectives, and then see how it develops. Again, in these CSIs are not intended to provide finite answers, but really to open the right questions and open the place for further discussions, interactions, and hopefully research. Any comments, any ideas, I think Alfonso already raised the hand.
Yeah, thank you, Igor. Thanks to Claudia, Žan, and Roberta for the presentation. I just have a comment. Do you think it could be possible to develop artificial intelligence technology for patients' self-regulation in such a way that each patient could have their own medical assistant?
So basically playing the role of medical support, helping people self-medicate. Any comments? You can post the comments, questions to the introductionists or to other members of the podium. Yes, Alfonso.
Yeah, that's for Claudia, for instance, the questions. It's a way of using the law of requisite variety.
Somehow the question is not easy. It's not an easy question, and it is not easy to give an answer. But I think that somehow we are going through more and more the future of healthcare with the community-based healthcare will go toward customization of the care. And so technology such as artificial intelligence, being adaptive, integrating with different patients and having the capability to adapt to patients could allow us to have a more and more customized healthcare services. Perhaps the idea of a personal healthcare, I didn't remember, how did you call it?
A personal assistant, medical assistant.
Yes.
It's like an own avatar.
Yes, perhaps it could be a possibility if also engineering will follow the evolution. Perhaps it could be one of the evolution of artificial intelligence and evolution of customized care in a view of community provision, community-based provision, because the personal assistant, the healthcare personal assistant, which interact with the patient, will for sure allow a community-based and perhaps home care-based healthcare provision, from my point of view.
Short comment before handing it over to Ram. I think that will require a major rethink on sharing the data, because if medical institutions and medical industry have the data, which is knowledge, which is required for establishing such self-medication assistant, they need to share it. So the data will not only flow in the directions from the patient to the institutions, but knowledge will flow back. And this is a major shift, I think. But let's hand it over to Ram.
Hey, first of all, thank you for the presentation. I had a question, if you could elaborate a bit more about what exactly you mean by community-based healthcare, maybe some practical examples.
A community-based healthcare is based on community healthcare facilities. That it is not based on hospital provision, but there are more facilities which are characterized by proximity to the patient, so are quite more than the hospitals and are more close to the patients. So patient has got like a closer facility in which they could be treated. And that integrate also with the home-based healthcare provision. So perhaps the patient is treated through home-based provision, and when necessary, go to the healthcare facility instead of the proper hospital when possible, because not all the pathologies, not all the conditions could be treated in community base. Perhaps Professor Saviano would like to say something here also.
Just a very short comment to the Alfonso's question that led me to think about the role of artificial intelligence to empower the people's self-regulations. I think, of course, in terms of preventative care, which is the most disregarded from healthcare systems so far, and people are coming of every more used to use facilities like we say Dr. Google, no, to find solution interpretation to their health problems. So putting focus on the way artificial intelligence can sustain the self-management of healthcare by individuals. Of course, no, I don't mean care or rehabilitation or other kinds of typical healthcare interventions, but specifically what is the the full world of prevention. We are very keen as consumers to use ex-suppliers to take care of our life every day, but we don't have an effective approach to this. We are in the sea of the web, and this is very risky. So possibly an area of actions should be to develop devices that can help these self-regulations of care, self-control, self-monitoring, and to keep people increasingly aware of the value of safeguarding health.
Okay, and yes, let's hope we will have the follow-up to these discussions also in the next, not the really next, but in the CSIs, which will happen in the autumn. Okay, let's hear it from Andy now.
Oh, thank you very much, Igor.
Well, I gave you the word before, but
So I have two questions. One is, how do you assess the fitness of healthcare solutions so that the most important aspects of healthcare actually improve through your research? And let me give you an example. What if you have a $1 trillion healthcare system, or $3.3 trillion healthcare system in the US, and you got better results if you didn't spend a single penny on healthcare and everyone did yoga and ate well? What if, just saying, what if that was the case? How would you know if you don't measure the fitness of the healthcare system? And what measure of fitness are you actually using? Is your measure able to discover these things? Secondly, you don't appear to be systematically searching networks of interventions, and therefore you have not accounted for network effects, which I believe might have an exponentially larger impact than any single intervention in healthcare, exponentially greater. Limiting ourselves to standalone interventions effectively, in my view, and I'm trying to prove this in a model, but it effectively limits us to either a poor quality of healthcare for everyone, or high quality healthcare for a few. What do you say about this? So first question is fitness. How do you measure it? Second question is, you seem to be excluding network effects. What do you say about that?
So the fitness is the first question, and the networks effect. Can you maybe, Andy, elaborate a little bit more on exactly how you can measure that, or how you can elaborate on the network effects?
Okay. So as an example, I might have process for collecting patient data. I might have a certain process for submitting medical insurance claims. I may have a certain process for paying doctors. It's possible, actually, you know what? Let me go to a more abstract perspective. It's possible by taking networks of businesses. You have one business that has outputs, which are inputs to the next business, which outputs inputs to the next business, and so forth in a circle. It's possible to create a network of businesses that is self-sustaining, so that whatever impact you could achieve through one business, because that chain is self-sustaining, you can multiply that impact by however many times n that chain executes. And that turns out to be a pattern, a design pattern that you can replicate in not just the running of businesses with existing products and services, but you can actually replicate those networks in engineering processes, in research processes, and in all of those, they can radically increase whatever outcome you're looking to achieve per dollar. So in healthcare, for example, these network effects, according to my conceptual examples, have the potential to save up to 50% of the 3.3 trillion that's spent in healthcare in the States. And that's just looking at some very basic networks. Those can be, I believe, can radically increase access to affordable healthcare per healthcare program dollar spent. Does that make sense when I say network effects now?
Yep. That's
okay.
So basically, this is why we are here for, because it is about cyber systemic interaction, and that requires a systems perspective. And I think you mentioned at least three methods of getting in: viable system approach, system dynamics, agent-based modeling. If I got it right from your presentation, so maybe any of the introductionists or maybe somebody else from the environment, what would you propose to deal with this network effects? Yes.
I think I want to come in.
Perfect. Yes, let's do that. Raul.
I think the fitness and networks are very, very significant. Now, I think I want to connect with the problems of organization. Somehow, artificial intelligence is something that is affecting the relationships between different participants in a situation. And it is that aspect that I believe might be of significance and relevance to developing artificial intelligence. So when you are trying to develop networks, somehow you need to have a more clear which are the organizations that are somehow being affected by the developments of artificial intelligence, and at the same time affected the contributor or the participants in the situation. So what I am asking is, how far have you been discussing about organization structures, about how is it that regulation and self-regulation are related to these organization structures, and how is it that these elements related to aspects of contributing to the balancing of problem situations that different participants may have with the actors who are developing artificial intelligence.
So are we going to follow that? Should we go on basically, because we were discussing the fitness of how to measure the fitness of the system and the network effects which came forward with organizational structures. Francesca, do you have a question, or would you like to comment further on to this topic?
No, I would, as first of all, step, thank you for the organization, and thank you to Claudia, Roberta, and Žan for their presentation. I would only to add a comment, because Claudia has cited before the viable systems approach that, as you know, it's a key topic for me. And especially if applied with reference to the healthcare sector and the healthcare domain, because it is a sector in which, as the presenters have underlined, involve a set of stakeholders, of actors with different value and with different expectations. So another elements that we can imagine to add in the framework and in the discussion that is has been anticipated by Alfonso with reference to the requisite variety is related to the consonants, because basically the healthcare system now, especially in Italy and in Europe, has a relevant problem, is facing a relevant problem related to the relationship between provider and user of health services. between doctor and patients in different terms. And perhaps the technology, the virtual intelligence, the artificial intelligence, the virtual reality could be a useful instrument for imaging a new way for interaction with the young generation, because several scholars has underlined that in the virtual reality and thanks to the technology, there is a low attention respect to topics such as the privacy, the use of information, the defense of information. So basically, it's possible to imagine that in the next future, the healthcare will be overcome the problem related to the privacy, to the data collection, the data use, thanks to these elements. But it's clear that it is needed to image and framework for understanding which kind of data we need to collect and in which way it's possible to promote the fitness, as Professor Espejo has told before, the fitness for the model, because the real problem is to invest in the technology, to spend money for the technology, but the technology become a simple instrument. So there is not the evolution in the next step, thanks to which it's possible to rethink the model, the business model for a healthcare system. This is all.
Thank you. Francesco. Now you have put the virtual reality in the play. Come on, and I'm trying. We are widening the problem as we speak. So, Jerry, any comment on the previous reverberations, or would you like to add something?
Actually, both. Thank you very much. I enjoyed the presentations and find it to be a fascinating perspective. Some of you may know that my background is in biochemistry, and I spent much of my career with the National Institutes of Health before moving into mathematical modeling of living systems. So this is more from the patient side of the perspective of how this might contribute. So the first thing that teed me off was the concept of viable systems approach, the VPA approach. Of course, a patient is also a viable system. So you have a very deep logical conflict here in how you're talking about systems theory and how you're talking about, for particularly feed forward and feed backward loops that are intrinsic to a network, both at the level of the individual patient's body and their consciousness, as compared with the network of a computer network where there is purely a formal connection in terms of information processing as signals. So the very nature of signals themselves differ in the internal viable system of an individual patient, because that individual patient has an individual genetic system that expresses itself at all times and in many, many different ways. And that's unique to that individual. One has to contrast that with the possibilities, or I should say the certitude and the almost absoluteness of the computer network approach, which underlies viable systems approach, where there is this absence of diversity of approaches that are needed. To what extent these two notions of viable systems, one developed on broad physical mathematical generalities, and the other based in biology of the individual genetic system and its individual responses, seem to me to approach a very deep conflict here and how such systems are going to be implemented, and how you can even evaluate the fitness of the system for a particular patient, and how you would measure this in terms of network effects just boggles my mind completely. I cannot find much to connect these different notions of viable systems. So thank you.
Thank you, Jerry. Now, I think, first of all, you threw a glove people who were dealing with viable systems throughout their life. So it's going to be an interesting one. But the second one I think you opened is very, very interesting. Basically, we have these two dual perspectives. One is on the from the perspective of an individual patient. And the second one is, and I will claim to say it's an institutional. So basically, how to support the institutions and the industry to work within this health system, which tend to have this approach of mathematical logics, which you mentioned. So I'm not sure if it's the issue opened, if it is related to the viable system approach, we can discuss that, or is it basically more fundamental, from the perspective of the institutions dealing with the system and the individuals who are there. And I see Jose having his hand up in the air.
Yeah, hello, Igor, and all of you, and thanks very much for the presentation. That is quite interesting for Roberta, Francesco, etc. No? I have some reflections. Well, the first one is that the issue at hand is tremendously complex. This is the first thing I would like to say. And after saying that, I would say that this requires that we consider many levels and many views from the issue. I just took some summarizing very briefly and very drastically. I see one kind of complexity that is related to the organization at different levels. The whole society, the community, the different organizations that are related to health, the hospitals, the primary attention, the individuals, and on parallel, the industry, the pharmaceutical companies, etc., the insurance companies, etc., etc. So we have at that level, we have a bunch of actors, huge actors that are interrelated. So for that, I think that the use of the VSM, as was already mentioned, I think that may help a lot to clarify the structure. This is one first reflection. And if we move recursively, we can get into the different elements of this broad, let's say, cosmos. If we go to the hospitals, we will find there the cosmos of the hospital with all the specialities, the pharmaceutical assistants inside the hospital, the surgery, etc., all the different functions. And here I see another level of complexity that relates to aspects. One is the organizational aspect, processes that was mentioned by Andy, the processes, different kind of processes, one thing. And the other thing is the technical aspects, the knowledge, the medical knowledge that has to be available to all the different actors at different levels, doctors, surgeons, assistants, etc., etc. So this kind of knowledge has to be available. And this connects with the reflection that was done by Raul and by Alfonso of self-regulation that will demand autonomy. The autonomy that goes together with knowledge, and here is where I see artificial intelligence helping, that may say, okay, you are going to have autonomy, and also I will provide you knowledge, the knowledge that you may need to help the one that you already have. And this is quite important from all points of view, from the point of view of the patient, from the point of view of the cost, from the point of view of the motivation for the doctor, etc., etc. So we have there another universe to handle. And then we have, if we keep going down, we find the patient, the individual. And here we find all the research that has been done. By the way, I remember a presentation done, I don't remember the name of the doctor that made the presentation there in Rome, when it was the WASC in Rome. And he was talking about the new, let's call it medicine, that is a medicine that is different from the statistical medicine, averages of results of a technique, of a medicine or whatever, the percentage of people that is aggregates. And he was moving to the individual. Now the medicine with the artificial intelligence, maybe, that can foster this kind of individual and personalized medicine. That is another universe. Yeah? That is to find out what is your genome, and these are the things that you have probability of suffering, and these are the things that we can prevent, and these are the treatment if you cannot prevent it and you already have them, etc., etc. So we could have another third level of complexity, but where the artificial intelligence could also help. And just to end up and not to dedicate too much time, I would call for the help of artificial intelligence to provide a kind of control panel to each individual in the whole system, no matter if it's doctor, patient, assistant, etc., that is adapted to his specific function. And this control panel would indicate the main key variables to monitor. And this, the artificial intelligence and the big data, etc., could collect all this information, handle it, and adapt it to the doctor, to the nurse, to the surgeon, to the patient, etc., So I see the space for the artificial intelligence use is tremendous, as I can imagine. And I think that is all by the moment I would like to reflect. Thanks very much.
Thank you, Jose. It was, you've listed a lot. So basically, recordings will be available. And I think we will need to listen to those recordings very slowly because it's very concentrated. Now, I would just add 2 words to Jose's presentation. So usually it's not the AI who is friendly or unfriendly. It is the people who are organizing, developing, or organization. The question is, who will, let's call it, own, design the AI who should support us? I think this is really important because if these are representatives of the patients, it will be completely different than if these are representatives of the health industry or health institutions. I think we need to think about that as well. And saying that, Lowell, you have...
Yes.
Yes.
Just 2 comments building on Raul and Andy's insights about network effects. Gregory Bateson had 2 sayings. One was, in order to think straight, you need to describe 2 interacting systems. And we continually focus on one system and how it operates, not how it interacts. And with that, the work of Ron Coase, who was the Nobel laureate on economics, has said the problem of economics and everything else is the turbulence between information, and that's why an organization is created. The question for artificial intelligence is, how do you allow that turbulence to be moderated, modulated, etc.? And in order to do that, you need a perceptual thing, not a conceptual aspect, to describe the interaction of the system. And the second thing he said was, without knowledge of the whole, disaster is inevitable. You have to know the whole interactions. And what's key, and what's happened with the work with the auto industry, is how they looked at supply chains and took care of the turbulence between actors, institutions, regulators, etc., that really increased the network effect that Andy talks about between all the interacting components. So those 2 things, one is you need to be able to describe a system. So the question to artificial intelligence, not as what you know, but the wisdom to see the interactions both internally and interactively between those, because that's where the network effect that Andy keeps on emphasizing, and that was emphasized by the person who wrote Medical Nemesis, Ivan Illich and others. That network effect, or learning webs, is where we have to be able to do the organizational task that AI has not done as.
Thank you, Lowell. I keep on hearing organizational issues, and I think I've heard it like 4 times. So I do expect that, we are currently focusing on the medical data and use of AI in that part. What I think we all are reflecting, let's use AI in the organizational aspects. And I think Andy was going there. Were you, Andy?
Yes, I was talking about AI not just in the networks of processes through which organizations interact, but the networks of processes through which anything interacts. And if I might continue, or I had a point to make, or did you want to finish?
No.
So some of the earlier speakers were talking about, I think one of them was Lowell Christie and the other one was Jerry Chandler. Actually, I think everyone mentioned it one way or the other. But we need to find optimal outcomes for every single person. And what's optimal for one person may be different from another. And when we talk about fitness, we need to assess we need to assess the fitness of each individual in order to assess the collective fitness, in order to assess how the healthcare system impacts the entire population. So in order to have visibility on the fitness of the individual, I wanted to point out the usefulness of a network approach there as well. One can see every human system as moving through a network of the states of functionality that it can occupy. So, for example, the states of functionality that the mind can occupy are concepts. And the mind can move from one concept to another concept through reasoning processes. So each of our systems moves through what you might call a functional state space. And we are a hierarchy of systems, and therefore we move through a hierarchy of functional state spaces. So in this sense, every single medical intervention causes us to trace a unique path through our human state space, which is the functional state space of our individual human system. And within this functional state space, fitness has a very well-defined meaning. It's your fitness to navigate all of those paths. So the bottom line is, in order to explore these network effects, in my view, and I hope that wasn't too much of a departure from the conversation, but in my view, we have to adopt some sort of a functional state space-based approach, where these functional state spaces can reflect any possible impact of any possible system on us, on any individual, so that we can objectively assess what the collective impact is. The problem with AI as it is being used right now is that what's good for me as someone who's living in the Caribbean right now is not necessarily what's good for Igor, who's someone who has very different genetics, who's living in Slovenia. So the current way AI is being deployed in a centralized manner, it assumes we're one size fits all, which is more of a means of control than it is a means for upliftment and enablement. That's it.
But
Igor?
Yes, Raul?
Yes, I think I want to go further with some of the aspects of organization, and in particular with the issues that Jose developed with the different levels and recursions. In my view, artificial intelligence is very, very much connected to correcting imbalances in varieties, correcting imbalances in complexity, so that we have the two parts, the two systems in interaction. So the emphasis in interaction is well received. And the next thing is corrections and imbalances, which is precisely the issue of self-regulation. So you are correcting imbalances when you are dealing with varieties at different levels of recursion. And that is where I believe artificial intelligence has some prospect. It is important to avoid the misuse of artificial intelligence. In a way, we now know that people are not particularly happy with the ways in which possibly in the future, this artificial intelligence may affect our organizational levels. So that's something that perhaps is worth paying attention to. And I continue insisting in the idea of correcting imbalances in variety. And this correcting relates to performance, relates to interactions, and possibly to ways to make better use of artificial intelligence. Perhaps the other point I wanted to make, which is more directed to the latter points of Lowell Christie's comments, I think he was referring to mathematical and biological viable systems. One of the characteristics of the viable system model as developed by Stafford Beer was precisely to be transdisciplinary, so that it was not only focused on one discipline, like in this case, mathematics or biology, but it is by creating the transdisciplinarity or by studying the transdisciplinarity, we are able to generate models which cut across social systems at multiple levels and with different purposes. That's where I think making the separation between one and the other perhaps is not as helpful as it could be.
Thank you, Raul. Now, our time is up. Jose, you have the last comment?
Thank you. Just a last a brief comment. Since we have so many fields where artificial intelligence could have a role at many different levels, I would just choose only one. And this one would be at the first level. And with that, I would feel almost relatively happy. And this, that if artificial intelligence help us to make a decent balance of resources through time at the different levels, the hospitals, the primary attention, etc., and together with the motivation of the professionals. If that is attained, I will be already happy. Because what we are suffering, without going into the details of more complicated data, etc., this very elemental primary stage, that is, the doctors should be happy and should be willing to stay where they are and not to trying to run away and find another place so they will be replaced by new doctors, etc., etc. That is very inefficient and a disaster for the patients. So if the artificial intelligence would help us to put some kind of control of balance at that top level of interaction of hospitals, primary attention, individuals, etc., and at the same time motivating the professionals so they want to stay. And this would make a connection, just as a lateral for the next meeting, for the education system. Because you have to have the faculties producing the doctors. They have to be motivated to, willing to study what is necessary, not what is paid, very well paid. That is happening now. In Spain, there was a selection not done by the doctors, and they were choosing the more well-paid specialties, and the other ones were not chosen, and they were empty. Nobody wanted to go there, etc. This kind of imbalance is very inefficient, and I would be happy if the artificial intelligence help us to handle at least this first level kind of problems. Thank you.
So I think Anna Roberta mentioned that. So yes, well, you know, this particular CSI are focused on healthcare will be continued with the two more who will be not as general but more specific, and they will come in at the program during the autumn. So basically, let's call it in September. We will let you know. But yes, Anna, tell us.
It's a pleasure for me and an honor. Why not? Yes, yes. And I agree with Prof. Perez Rios. The big problem in this way, in this moment, with the outbreak of the COVID-19, the implementation of the digital technologies in healthcare sector is relevant. But in this moment, in Italian context, but also I think in European context, is the skill, technical skill, educational skill of healthcare organization. And this is, for me, in my opinion, the first, the principal, the critical, the key barrier to the adoption and to the correct adoption of the digital technology in healthcare sector.
Igor, I'd like to make one small comment. Is that
Yes,
okay?
Andy.
In response to the comment made by Jose Perez Rios, what if we can't solve that problem? What if our decision-making process simply doesn't have the capacity to resolve that? At that point, the problem becomes improving our decision-making process rather than trying to solve that immediate problem. How do you know when you've crossed the point where improving the decision-making process is more important than the problem itself?
So basically employing all the efforts to self-regulate for the self-regulation's sake. Maybe a short feedback by Jose.
I see. I think that I understand what you say, Andy. My focus is on the designing the system so the time is taken into account. Why I mention the time? I mention the time because, for example, one of the main problems of the inefficiency and bad quality of the medical assistance today is generated 20 years ago, when they knew, when the doctors have 45 years, they knew 20 years ago that after 20 years, they would have 65 years and they would retire. So 20 years ago, if they took into account that within 20 years, that number of doctors will disappear, then they would design the system to fit in 20 years ago enough doctors. And so when the time comes today, the present, we would have these doctors, new doctors that will replace the ones that disappear because they retired. This was not done correctly. This is one example of the design of the whole system. And if you take that and you divide it by specialities and by primary attention, etc., the complexity grows. So if there is not a global view of the whole, taking into account the time and the movements of the doctors in and out through a period of time, if you take that into account, you can have a design that it works probably correctly. If you do not consider these kind of variables and you just go acting according to the circumstances, the money available, the number of doctors, the offer that they receive from other places, etc., and you are just adapting on real time, you have a very inefficient way of operating. That is what we are suffering. This together with another key aspect, that if that happens, the doctors, if the organization is not adequately designed, that we were mentioned, Raul and some of the other present mentioned the organization. If the organization has not correctly been designed from the point of view of functions, attributions, autonomy, self-regulation, etc., the motivation suffer. And if the motivation suffer, then you will have all these kind of problems aggravated. So this is why I would stop on the first level, trying to take into account these huge pieces that are very relatively few, but are very interconnected and very severe if they are not taken into account adequately with the time included. This is, I don't know if I explained the idea, Andy, if I answered your question.
Yes, well, I think you've opened a really huge pathology there, and hopefully in one of the next sections sessions, we will be able to maybe open the issue more closely. So one more time, yes. So we're gonna have really interesting discussions, interactions in the autumn. But before going to the autumn, next month, I think on the 14th of June, Tom Scholte and Hernan Lopez Garay will get another point, which is not really related to health systems, but it is going into cyber theatrical arts in modeling and understanding the governance of higher education institutions. So remember the date, 14th of June. And that particular day, that particular topic is really related of actually what we are trying to do here. So I will try to make them reflect for participating. Thank you, Claudia, Žan, Anna Roberta. Thank you all the system thinkers, cyberneticians who have devoted your energy to that. And hopefully to see you on a different topic on the, what was the date?
June 14th.
June 14th. Thank you, Valentina. And we are really looking forward to this completely different perspective, and then coming back after the summer months to see us again. Yes. So thank you for being here. Thank you for your energy, your effort, and see you soon. Okay.
Thank you for the opportunity and for your time.
Thank you.
Have a nice day.